We can see we have people from entire country. We have good SHAs, we have NGOs, we have all walks of life of people. We can see that. As a National Health Authority is the apex body responsible for implementing India's flagship public health insurance assurance scheme called Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And we is instructed with the role of designing strategy, building technology infrastructure, and implementation of PMJY and National Digital Health Mission. NHA oversees the nationwide implementation of PMJY by state health agencies established by the individual states operates it. NHA leads to implementation of Ayushman Bharat Digital Mission, collaborating closely with various ministries, state governments, private sectors, and civil society organizations. We at NHA hold PMJY and ABDM virtual training programs, aimed at enhancing the understanding and implementation of Pradhan Mantri Jan Arogya Yojana and Ayushman Bharat Digital Mission. And these are very important to us because in PMJY, people can avail benefits in different ways. We have so much of packages, and we also have packages for pneumonia, and it is helpful for the patients who are below the poverty line and for now the 70 plus people also. Basically, if you see, the participants are also trained for registering beneficiary, how they can register using digital platforms or healthcare access, managing. We also manage telemedicine consultations for ensuring the smooth service delivery. The virtual programs are also educate stakeholders on new policy guidelines, what are coming up. People should know about it. That is our aim and ambition, that we percolate it to the down level, and it reaches the last mile. These trainings are aims to empower individuals to efficiently use technology and healthcare delivery, ensure seamless coordination across the different health departments, and improve access to quality services. It is available through government portals, often includes webinars, self-paced learning modules, and interactive sessions. Nirantar Shiksha is a part of our virtual training calendar, and it is held every month, and especially on the days like today we have Pneumonia Day. We are World Pneumonia Day, so we are celebrating this webinar and trying to help societies, individuals, SHAs, and everybody to come forward and learn, because learning is very important, and prevention, we say, is the better than cure. So important is that everybody learns here. And on we can say that pneumonia, we all understand that it's causes because of bacteria, virus, and fungi, but it can spread. And today we are fortunate to have Dr. G.C. Khilani as a guest speaker, who is well-known personality in the country. He's the chairman of PSRI Institute of Pulmonary Critical and Care and Sleep Medicine. He has a 41 years experience. Now just imagine, he was also, and I have a chance to work with him. He was also head and professor of Department of Pulmonary Medicine and Sleep Disorders in AIIMS Delhi. He expertise in pulmonary and critical care medicine, his fellowship in critical care from Mount Sinai Medical School of New York, USA. He's the chairman of Credential Committee of Indian Society of Critical Care and Medicine and member governing body of Indian Chest Society. He was Vice President of National College of Chest Physicians from 2007 to 2009, President for 2 terms for National College of Chest Physicians from 2011 to 2013, Chairman Credential Committee of Indian Society of Critical Care from 2011 to 13, Member of Council of Regents for 7 years of American College of Chest Physicians, Member Executive Council of Indian Society of Critical Care Medicine from 2008 to 2010, Member Governing Body of Indian Chest Society 2015 to 17, and many more. And we cannot, just it's like सूरज को दिया दिखाना होता है, उस तरह से हम कोशिश कर रहे हैं बताने की, but we don't, he is well-known personality, and he don't know such much of introduction because well-known personality. He's a senior editor for Critical Care Lung India and member of many editorial boards like Journal of Critical Care Medicine, Indian Journal of Chest Disease, and Allied Sciences. We at NHA feel privileged to welcome you, sir, and it's a profound privilege, which all should say, that you are here with us and you accepted our invitation. So thank you so much, sir, for joining. And we have people, let me inform to you, sir, because we have people from states, SHAs, we have people from NGOs also, who are working with us in a different, and we have people from the hospitals as well. So this is basically from different walks of life, and people would like to learn from you what exactly we require when we talk about pneumonia. And nowadays, AQI is so high, sir. We have respiratory problems so much high in especially in Delhi and Bombay, like, and we need your expertise and guidance how to overcome this. Thank you so much, sir. And over to you, sir.
Thank you so
Thank
much.
you.
Over to you, sir.
Thank you, Dr. Vinita Srivastava, and generous introduction. And also I came to know about what a fantastic work your ministry is doing. Am I audible?
Yes, sir.
Yeah. And my slides are visible?
Yes, sir.
Yeah. So I was not aware of so many activities that you are doing, and so thank you very much for inviting me, and it is my privilege to be talking to you. And next 45 minutes, so I'd like to clarify two things, and I know that I'm talking to the senior most physicians of this country. They are working in different capacities. But having worked in this area for several decades and conducted some research while being in institute and here at PSRI hospital, I'll be sharing my experience and some of the studies. The time given to me is enormous. The platform is amazing. So my confusion is how much to cover and what not to cover. So what I've tried to do is to cover simple pneumonia to hospital-acquired pneumonia, and I'll be touching upon hospital-acquired pneumonia in ICU, that is ventilator-associated pneumonia, only little part of it. If I am able to do that in this much time and be of some use to your knowledge and practice, my job will be done. So, Sir William Osler, whosoever reads medicine knows about him. He is considered father of medicine. And he said in 1901, when there were no antibiotics, the most widespread and fatal of the acute diseases, pneumonia is now captain of men of death. And more than centuries later, the most common cause of infection-related mortality continues to be pneumonia. When the penicillin was invented in 1942, everybody thought that it's the end of infection. And because of the Streptococcus pneumoniae was the causative organism for pneumonia. Its name was given Streptococcus pneumoniae. It was that it is the only bacteria which causes pneumonia. So the William Osler was quite wrong in the way that he didn't think that even after 100 years, it will continue to be most common cause of infection-related mortality, affects 4 million adults in the United States, and is the sixth leading cause of death all over the world. And we saw the COVID. What was COVID? COVID was pneumonia. And there are so many deaths all over the world. But there has been changes over the decades and centuries, that there is a changing spectrum of etiologies, as Dr. narrated. It can be bacteria, it can be virus, it can be fungus, even it can be tuberculosis, or it can be sometimes non-infective also, and other causes also. Even rickettsia can cause pneumonia, even atypical pathogens can cause pneumonia, and fungi like PCP, and I'll come to these things later. And what I'll be talking about is increasing resistance to pathogens, to antimicrobial drugs that we are facing, and I'll be actually spending a lot of time on that. And life expectancy in India was 32 years when we got independent. Today we are at 72. So there is increased number of susceptible population, not only because of the age, also the cancer survivors are there, chemotherapy is in between, HIV came. So because of this, the lung infections have become very important. In one of the studies conducted in Pune involving 700 practitioners, 50% of the patients had attending to the general practitioner had some respiratory symptoms. So the defining pneumonia is, we divide it into two. One is called community acquired pneumonia, that is pneumonia that is in the community setting or acquired outside the hospital or healthcare facilities. I'll be calling it CAP for the simplicity. And hospital acquired pneumonia, when it occurs 48 to 72 hours after the person is admitted to hospital, and when it is associated with intubation, then it is called ventilator associated pneumonia, and I'll be calling it VAP. Now I start with my presentation with two cases that these are my cases while I was at AIIMS. This was a 25 years old male. He's a resident of Delhi. He's presented with fever, cough, and expectoration for 7 days. OPD. This was 21 years old male, Indian origin. He was residing in UK, had fever, cough, and expectoration. Came to the OPD, and this is the X-ray. You can see that he has a left lower lobe consolidation. The young man has also a left lower lobe consolidation. So both were started as per the guidelines with co-amoxiclav and azithromycin. This patient was also started on the same medication. Now, the 25 years old male improved, where this young boy, who was a well-nourished boy, slightly obese, he worsened. So, and then we did a CT scan. You can see a consolidation with air bronchogram and a little bit of pleural effusion also. So we started looking at the microbiology. And so what do we do? So you have to find whether indeed it is caused by bacteria or it is a drug-resistant bacteria or something else. So when we investigated, he was found to be AFB smear positive, and he was put on ATT and then followed up with me for 9 months and got cured. What I'm trying to say is that what we said in the beginning, that pneumonia is not one. Pneumonia does not always mean just antibiotics. The causes of anemia could be many. So the major culprits remain pneumococci, H. influenzae, and other bacteria, but pneumococcus is number one. Still remains to be number one. The atypical organism like a mycoplasma, chlamydia, and influenza virus, also depending upon the situation. Like COVID time, the COVID was number one cause of. So among the etiology, if the outpatient, the Streptococcus pneumoniae, mycoplasma, hemophilus, and inpatient Streptococcus. So whether it's an outpatient or inpatient or ICU, the Streptococcus pneumoniae remains number bacterial cause of pneumonia. Bacterial, not necessarily virus. But if the patient in the ICU, I'll come to it later, gram-negative bacilli and staph will come into picture. And there are other viruses also, influenza virus, adenovirus, RSV. Now with the availability of investigations, we are able to diagnose like influenza very commonly. And this slide is almost 10 years old, and coronavirus is always the cause of pneumonia, but we never used to pay any emphasis till the time it came. Tuberculosis, fungus, parasites, and leptospira, as I said, could also be causes. Now, this is a study which was published quite some time back, but in 56% of the patients, no causative agent should be identified despite in the advanced setup. So that should be understood that quite often we do not have bacteriology or microbiology. So we have to depend upon the epidemiological data and the guidelines for starting the antibiotics. But Streptococcus pneumoniae remain the most common. This study conducted by Dr. Seema Jain, published in New England Journal, conducted in US. And this study was actually very well organized with more than 100 cases, which showed that human rhinovirus was number one cause, influenza number two, and then came Streptococcus pneumoniae and other microorganisms. It should be understood that viruses are number one cause of pneumonia as per the data goes. Now, this is a study that we conducted at All India Institute. Dr. Priya was my MD student, and we studied 50 cases of severe CAP and found that Streptococcus pneumoniae was commonest, but 10% cases were actually tuberculosis. As I showed that case, these cases were, AIIMS, it's so difficult to get a bed. Only serious cases are admitted. So 8% cases who presented just like any pneumonia had tuberculosis. So never forget tuberculosis when you are investigating for pneumonia. And all this study, these patients who had tuberculosis had short history of 7 days, 5 days, 5 days, and 7 days. So coming to it, after the etiology, how to assess severity. When the patient comes to your hospital or the clinic, you ought to decide, should the patient be treated in OPD, or should this patient be treated in the ward, or I should straight away admit him into the ICU. For that, there are several scores, complicated scores are there, but the simplest is curve score, that is only has got 5 parameters: age more than 65, level of consciousness, urea, respiratory rate, and so the third score is 0. Patient remains in the outpatient. If it is 1, outpatient. If it is 2, it is inpatient. 3, it is inpatient. If the 4 or 5, the consideration should be of in the ICU, because as you see, the mortality goes up. This is a very simple score which only requires only urea, and rest all or clinical can be used for. Besides that, severity can also be assessed with which are indicators of poor prognosis are if the respiratory rate is more than 30, if the PaO2 upon FiO2 ratio is less than 250, or PaO2, that is oxygen level, is less than 60, if the patient is requiring mechanical ventilation or X-ray, there is multilobar involvement, if there is hypotension requiring need of vasopressor, or if there is a reduced urine output. If these factors are there, these patients require ICU. And so these are the major criteria. That is ventilation and septic shock, and there are minor criteria. I am not going into details of that. So coming to the how to achieve a microbiological diagnosis, and this is very important, and it depends upon the facilities, whether you are working in the hospital or you are working in the district center or OPD. I wouldn't know that. Radiology is most important. X-ray and CT scan is very important. I mean, like microbiology, sputum, blood culture, bronchoscopy, serology, and I'll be just touching upon them because and also there are urine tests for pneumococcus, legionella, and atypical pathogens, which are not regularly done. The sputum gram stain is important, provided you have a good pathologist with you and the person has a good quality sputum. The yield of sputum culture is something like 34 to 86%. So the IDSA guidelines say if the good quality specimen can be obtained, then a gram stain culture should be done. Transportation is also important, and it should be sent to the laboratory as early as possible. And the blood culture. The blood culture is not to be done in the OPD setting. If the patient has ICU care or cavity disease or leukopenia or alcohol abuse or chronic liver disease or asplenia or positive pneumococcal urinary antigen or pleural effusion, which is considered as complicated pneumonia, the blood culture should be done. Value of imaging is very important. Previously, we used to frown upon people who used to ask for a CT scan, but COVID changed our thinking. So, X-ray is always necessary to establish a diagnosis. CT should be done to find out further intricacies. Suppose you are suspecting tuberculosis or you are suspecting TCP pneumonia or there is a complication, then the imaging should be done. Like this is a patient with right upper lobe, that is called lobar pneumonia. This is called H1N negative, H1N1 positive left lower lobe pneumonia. And if the lobar pneumonia, likely to be streptococcus pneumonia, Klebsiella. If the patchy pneumonia, then atypical. If interstitial pneumonia is there, then viral PCP and Legionella. Cases are seen more in anaerobes with Klebsiella and staph and fungi. And if the large effusion, now these are all arbitrary. There are no barriers as to, this blood bacteria cannot have cavity or cavitating pneumonia or streptococcus pneumonia always has lobar distribution. Does the radiology help? Yes, it does help in assessing the severity. Now, this is a patient with COVID pneumonia. No, but just by looking at, and this is a recent case that we had. And this is influenza A pneumonia. And can you make a diagnosis just by looking at the radiology? The answer is no. This is a patient, 70 years old male who had a Haemophilus influenza, and he also had concomitant influenza A. And this is our COVID pneumonia that we saw all the time during the COVID pandemic. So the blood culture, sputum culture, urine anti-Einstein molecular method, procalcitonin. Those of you who work with severely ill patients in the ICU would know that everybody asks for a PCT. So how useful are molecular diagnostic? I'll come to the PCT later. Now we have something like BioFire, which is cost about 10,000, 20,000, 25,000. It should not be done routinely. But actually these are real-time PCR. And there's a syndromic multiplex PCR. They contain like 12 beta and 10 viruses. They cannot detect beyond that. But there are certain advantages that there's the ease of testing and turnaround time is within 2 hours, you know which bacteria is there and what is their concentration. But disadvantage is difficult to differentiate between infection and colonization. And panel composition is predefined. If that panel does not contain that bacteria, it won't pick it up or the virus. Cost of the test is of course prohibitive, and these are commercially available. As far as now I come to the main part, that is how do I choose antibiotics? And I'm sure you would all want to know because when the patient comes to you, you do not have microbiology. What you have is patient symptom. You have an X-ray of the chest at best, but you have to give him antibiotics. There is an evidence that delay of even 2 hours in a severe case has adverse outcome in terms of mortality. This is Dr. Ashok Kumar's study from Canada. So, how to choose antibiotics? And this is the antibiogram of my hospital. Of course, these are hospital-acquired infections. The Klebsiella pneumoniae, you can see the cefuroxime 2% sensitivity, ceftriaxone 2% sensitivity, piperacillin, tazobactam. So much resistance is there, and this resistance is percolating into community also. Similarly, Pseudomonas has sensitivity almost average 50% to all these injectable antibiotics. So question is, why we are in this mess? We are in this mess because Alexander Fleming, who invented penicillin, in his Nobel laureate speech said, in such a case, the thoughtless person playing with the penicillin treatment is morally responsible for death of a man who finally succumbs to with penicillin-resistant organisms. Meaning thereby, he at that time said that if you use the antibiotic recklessly, you will be creating resistance. That is what is happening now. And we are in trouble. And for last 35 years, there is no new class of antibiotic has been invented because it's not cost effective. So in 2019, I was given the responsibility of framing guidelines, antibiotic guidelines by Indian Society of Critical Care. While I was heading the department of Pulmonary Institute, 52 experts sat down. Subsequently, in 21, the guidelines for procalcitonin, and then 2023, the antibiotic guidelines were updated or revised or written, and this was the publication 2024. These are a comprehensive guideline with 900 references and 113 pages. Not they cover not only lung, it covers urine, abdomen, brain, kidney, everything, and it gives an evidence-based guideline. So those who are interested, this is freely available on Google or whatever. You can actually go through it. So there are three guidelines that we have published over the last 5 years' time. So I'll go case by case about choosing antibiotics. So this is a case which came to us about 6 months back, 73 years old male, never smoker, known case of hypertension and diabetes, had fever, cough for 5 days, shortness of breath for 5 days. Wife was is a medical doctor, so she said, looked at the SpO2 was 89%. He was brought to the hospital, and this is the X-ray. You can say some infiltrate. His blood pressure was normal. He was put on oxygen, and there was basal crepitation. The TLC count was 15,000. So the X-ray was not helping us, so we did a CT scan. You can see left lower zone patchy consolidation. Also, there are some bronchiectatic changes are also there, with nodules are also there. And this is the enlarged picture of the same patient. So what is the bug and what antibiotic would like to give? That is a question that we have to answer, because when he came to us, he did not have the microbiology, whether it's or bacteria or fungus. He was a diabetic. So as I said, TLC count was high. H1N1 was negative. Procal was 0.75 nanograms, which is close to normal. And AFB microscopy was negative. The patient was started on cephalosporin, sulbactam, and moxifloxacin based on clinical presentation and radiology. And gram stain showed pus cells more than 25, and pyogenic culture was negative. So what should be the initial choice of antibiotics? That is a question. Now, these are as per the guidelines, Indian guidelines for antibiotic prescription. If the patient has no comorbidities, this patient had diabetes as well as hypertension, he was elderly. If the patient has no comorbidities or risk factors for MRSA or Pseudomonas, patient can be treated with amoxicillin, doxycycline, or macrolide, that is azithromycin or clarithromycin. However, if the patient is elderly or has got comorbidities, then you can give amoxicillin clavulanate, or you can give oral cephalosporin, or macrolide or doxycycline. And monotherapy with respiratory quinolone should be given only after ruling out tuberculosis. That you send a sample for 3 samples for AFB, or if the test is negative, then you can use quinolone. Now, this patient, if he is to be admitted, these are guidelines. If the patient is to be admitted, then you give a beta-lactam antibiotic plus macrolide. So you can give amoxicillin clavulanate with azithromycin. You can give cefuroxime with azithromycin or clarithromycin. Monotherapy with respiratory quinolones should be avoided in my personal opinion, and combination therapy with beta-lactam plus doxycycline can also be used. Some people are unable to tolerate azithromycin. Now, as far as the ICU is concerned, if the person is in pneumonia in the ICU, and combination therapy is always given in the ICU, and this is strong recommendation. And what should be preferred combination in the ICU? Non-pseudomonal beta-lactam, that is cefotaxime or ceftriaxone, beta-lactam with beta-lactamase inhibitor, or amoxicillin clavulanate plus a macrolide. That is one A, very strong recommendation and high quality evidence. If the patient is penicillin allergic patient, then respiratory quinolone can be used along with aztreonam. I have used aztreonam pretty often and found it a very useful drug. If macrolide cannot be used, a fluoroquinolone may be used. In India, in pneumonia, we don't want to use quinolone because quinolone should be reserved for treating tuberculosis, and already the quinolone resistance in tuberculosis we have reached 30%. And if you treat a patient with tuberculosis thinking it is pneumonia with quinolone, you are generating quinolone resistance and also delaying the diagnosis. So this patient, Streptococcus pneumoniae was grown, which was a sensitive strain, and so the antibiotics were good. So now the question is, can quinolones be used as initial treatment for community-acquired pneumonia? The guidelines say that for patients with severe CAP without risk factor for pseudomonas, the quinolones, as I said, should not be used. So this patient was continued on cefaperazone, sulbactam, and moxifloxacin, and according to culture sensitivity report, he received azithromycin and continued with the cefaperazone. After 1 week, injectable antibiotic condition improved, and ultrasound was done. There was no pleural effusion, and after 7 days, he was switched to cifodexime clavulanate antibiotic. And patient came to the OPD after 7 days, and his symptoms had resolved, and you can see the CT scan that pneumonia resolved. Now, few things. When to suspect anaerobic infection and pseudomonas, that should be understood. If there is a dysphagia, altered sensorium, coma, witness aspiration, putrid discharge, foul smelling, presence of lung abscess, empyema, or necrotizing pneumonia, then you should consider anaerobic infection, for which antibiotics like clindamycin or clavulanate or other antibiotics, and also metronidazole. Metronidazole we generally don't use for above the diaphragm infection. We use it for abdominal infection. My choice is because it covers anaerobes as well as staphylococcus. Risk factors for pseudomonas are chronic lung disease like bronchiectasis, frequent corticosteroid, prior antibiotic therapy, immunocompromised state, antral tube feeding, cerebrovascular accident. So now I go to the case 2, and we'll indulge in discussion later. I'll have to go a little faster to complete my presentation. This was a 44-year-old male with Ehlers-Danlos syndrome, was admitted with fever, bilateral chest pain, bilateral leg pain for 7 days, and progressive breathlessness. His heart rate was 132. He had fever, counts were high. Urea was also high, creatinine was also high, saturation was 92. His wife is a doctor actually. So both patients had wife. So diagnosis was severe CAP in the ICU. What should be the etiology consideration? Now this is the X-ray of that particular patient who had Ehlers-Danlos syndrome. You can see consolidation, the bilateral consolidation, some amount of pleural effusion also. We did the CT. The CT showed cavitating nodules. You can see here cavitating nodules. The blood culture came out to be Staphylococcus aureus. So this is a staph pneumonia which is acquired in the community, and patient is in shock. Patient is in has hypotension. He is hypoxemic, and also has high TLC count. And when the sensitivity was done, he was sensitive to all the drugs. So this was a MSSA, that is methicillin sensitive Staphylococcus aureus. So what should be the choice of antibiotic in Staphylococcus pneumonia? So whether it's bacteremia, pneumonia, or endocarditis, or skin and soft tissue infection, the drug of choice is cloxacillin. So that should be understood. In my practice, if the patient is very sick, our young residents prefer vancomycin, teicoplanin. They are weak anti-staphylococcal drugs. They should be reserved for MRSA. If you give MRSA coverage to these patients with teicoplanin, you are doing disservice to the patient. So cloxacillin is drug of choice, and of course other things are there. I have no time. So patient was started on cloxacillin. So what should be done next? We were thinking he was not responding to our satisfaction. So we did a echocardiogram and we found a big vegetation on tricuspid valve. So one should be a physician, not a pulmonologist, to look for what is the source of infection. So procalcitonin was also high, and these are the drugs for staphylococcal infection. I have not to go into this. And so he had infective endocarditis, right-sided with septic emboli. And so always try to find out source of antibiotics. Role of surgery, I'm not talking. And these kind of patients will require antibiotics for at least 6 weeks. So after the end of treatment, this was a vegetation, it became smaller, and ultimately you can see a normal functioning valve. And we followed up for 1 year, he is doing very well. So this was the X-ray which was done on 9th of May and 26th of June. So nearly cleared only with. These are the risk factors for MRSA, which are influenza, prisoners, professional athletes, army recruits, and so on and so forth. But if there is a cavitatory or necrotizing pneumonia, think of staphylococcus and anaerobes. Now, a word about duration of antibiotics. How long to continue? So, IDSA says that in OPD practice, 5 days of antibiotic is sufficient. In severe cases, switching to parenteral or oral antibiotic either with the same agent or class should be used in patients who are admitted. And the patients who are kept in the ICU should receive antibiotic for at least 14 days, and those with pseudomonas or aspiration pneumonia 14 days, necrotizing pneumonia up to 21 days. It has to individualize. But procalcitonin can be used for de-escalation, not for starting the antibiotic. If the procalcitonin level is less than 0.5 or reduction by 80% from baseline, that means that you can de-escalate. De-escalation means you can reduce the number of antibiotics or the strength of antibiotics and put them on simpler antibiotic or same class. Now I come to the last part of my presentation. I have 10 minutes left with me. That is hospital-acquired pneumonia and ventilator-associated pneumonia. For you who do not work in the ICU, this may be a little boring, but for the sake of completion, you should know that hospital-acquired pneumonia has a very, very difficult situation. So definition I have already said, when it occurs in the hospital, 48 hours after the admission, and when it is associated with endotracheal tube, it is called ventilator-associated pneumonia. This leads to increased duration of mechanical ventilation, ICU stay, and hospital stay. And this is a study that we conducted in All India Institute, where we showed that those who develop ventilator-associated pneumonia distinctly had higher mortality, p-value of 0.05. And if the person has ventilator-associated pneumonia, in those days, crude mortality was 71%. If the patient is admitted in ICU and ventilated, if he develops pneumonia, you say, my God, such a difficult situation that the mortality goes up. So I start with the case. 21 years old male. He had symptoms of cough, double vision, headache, neck pain, difficulty walking. He had fever, blood pressure was normal, otherwise examination was normal, MRI brain was normal, and but patient had to be intubated because he had deteriorating consciousness. Going fast, he was diagnosed as Guillain-Barré syndrome, and he was in ventilator. And initial X-ray was done. The next X-ray showed the shadow in the left lower throat, as you can see, ill-defined shadow. So increased FiO2 requirement, TLC was also increased. He had respiratory acidosis, and you can see this shadow in the. So is it a ventilator-associated pneumonia? That is a question. There seems to be loss of volume also. So does this patient has VAP? That is a question. So the diagnosis of VAP is very, very simple, very, very arbitrary. Clinical suspicion, if the patient has fever or he is deteriorating, and you do the semi-quantitative sputum culture of aspirate, or 2 or more serial X-rays showing deterioration in lung shadows. Many of the two, fever, leukopenia, leukocytosis, adult more than 70 years with altered mental status, purulent sputum. So, if the patient on ventilator has new onset fever, if he has leukocytosis, and X-ray is showing some change in the shadows, new shadows or enhancement of shadows, then there is a strong suspicion of VAP. So how do, but all definition does not sacrosanct. It doesn't mean that if in such situation all patients have pneumonia. So you have to differentiate from other conditions such as like this is a collapse of the lung with pneumothorax. This is a collapse of the lung, possibly because of a mass, not because of pneumonia. This is a fluid overload, bat wing that we see. This is interstitial lung involvement, and this is ARDS. And so you have to differentiate from diseases which can cause such kinds of shadows. And now the question is, should we do a bronchoscopy in this particular patient which I'm discussing? So either you can take tracheal aspirate, you can show a mini ball or non-bronchoscopic ball or bronchoscopy. Bronchoscopy is not difficult in a ventilated patient, and there's an advantage that if the pneumonia is here in the right lower zone, your bronchoscope can actually go here and get a good sample. But is it necessary? Does it help? So we did this study at All India Institute of Medical Sciences and compared it with tracheal aspirate and mini ball. This is the way we used to do mini ball using these two catheters and one mucus extractor. What we showed that mini ball was as good as bronchoscopy. And subsequently, the study from Canada came published in New England Journal of Medicine, which showed that bronchoscopy does not improve outcome compared to the tracheal aspirate. So, bronchoscopy must not be done in all the cases, but if there is suspicion of cancer or the patient is not responding, if there is an alternative diagnosis thought, then bronchoscopy should be done. So, this patient again had increased FiO2. This shadow was there. So, bronchoscopy was done, and you can see this mucus plug was found, which was removed, and this patient improved. So, this patient actually had collapse and not. The last case is another case. Wait a minute. So I'll go fast, so I'm skipping. Now, another case is a 51. This is the last case. 51-year-old male is a patient with cardiac and pulmonary sarcoidosis. He is on Visolon. He received antibiotics for 4 weeks for previous infection. He had dyspnea, chest pain, and he has respiratory. So there was a pleural effusion. When the pleural aspiration was done, pus was there. So whenever there is a pus in pleural effusion, that means empyema that requires insertion of a tube. So a ICT was put, it was sent for culture, and when the pleural fluid analysis was done, it came out to be MRSA sensitive to clindamycin, linezolid, and vancomycin. So, patient was put. So, what are the antibiotics effective against MRSA that you must know? Now, MRSA like vancomycin and teicoplanin are the main drugs which are used, and linezolid. Linezolid we reserve in India because that is reserved for XDR tuberculosis. Besides, daptomycin is good for bloodstream infection, and there are other drugs also. I don't have time to recite them. Between vancomycin and teicoplanin, both are equally effective, but teicoplanin causes less nephrotoxicity, and therefore we use it more. But to use vancomycin, you must have trough levels of the drug to modulate the dose, and which you don't need with teicoplanin. As far as the lung is concerned, the best penetration is with linezolid, and the best drug for MRSA pneumonia remains linezolid, but linezolid has adverse effects, and as I said, it is reserved for XDR tuberculosis. So this patient was put on 3 drugs. He was critically ill. He was improving, but then on 7th day there was hypoxia. He had a tube inside and developed. So, so what are the common organisms? What are the risk factors of infection with MDR pathogens? So globally, the hospital-acquired pneumonia, gram-negative aerobic bacilli, Acinetobacter, Klebsiella, and Pseudomonas are the most common. In India, GNBs are most common. MRSA somehow is less common in the Indian ICU. A risk factor for resistant infections are age, mechanical ventilation for more than 7 days, prior antibiotic use, severe sepsis, ARDS, renal replacement therapy, and systemic corticosteroid therapy. If I look back into my ICU, all my patients will fall have some or the other risk factors. So MDR is extremely common. What should be the empirical antibiotic therapy? Now this is important. Those of you who are working in the ICU, patients with VAP who are at high risk of MDR in the ICU, prevalence of MRSA more than 15%, an agent against MRSA, and 2 agents active against gram-negative organism, including Pseudomonas, and should be recommended. So, such patients, if the mortality is high, should receive 3 antibiotics. However, if the MRSA is low, which is in my ICU and also at AIIMS where I worked, then we do not use MRSA coverage empirically. And quinolone should be avoided as a monotherapy. And linezolid should be used for MRSA coverage. There's nothing to choose, as I said. Either can be used, but we don't use linezolid because of adverse effects. If there is the newer antibiotics have come in MDR, GNBs, ceftazidime, avibactam, and ceftalozone, tazobactam. This is not available with us. This is also not available, so I will not talk about it. Ceftazidime, avibactam is the latest drug which is saving us. Excuse me. You should also take a non-bronchoscopic or some sample to achieve. In our country, linezolid should be avoided. The duration of antibiotics should be 7 to 8 days. In simpler cases, which we do not see, the majority will require antibiotics at least for 14 days, quite often for 21 days. Now, final thing is prevention. The prevention of CAP. We know about influenza vaccine and pneumonia vaccine. I am not talking about COVID vaccine. The pneumonia vaccine, all persons who are more than 60 years of age, those who have lung disease, I have not put any slides. Those who have uncontrolled diabetes, those who have COPD or severe asthma, or they are immunocompromised because of the chemotherapy or cancer or HIV, and those who are asthenia should receive prophylaxis for pneumonia, and all such patients should also receive influenza vaccine. But as far as the prevention of associated pneumonia is concerned, hand hygiene, glove, gown, elevation of head of the bed, oral care, and all those things are important. And it is possible to reduce the rate of web by doing this semi-recumbent position, stress ulcer prophylaxis, DVT prophylaxis, sedation, lesser sedation is better, and daily assessment, early weaning is important. Finally, this is my last slide. It is important to realize that guidelines always cannot account for individual variation among patients. They are not intended to supplant physician's judgment with respect to particular patients. So, ladies and gentlemen, senior doctors, you should have knowledge, current knowledge, but your experience is also important, and your clinical judgment is also important. And I profusely thank Dr. Vinita Srivastava and the ministry and the NHA for giving me this opportunity to be with you. Thank you very much.
Thank you so much, sir. It was very well done, and people from different parts of country joined us. I mean, it was a huge. I know people who were asking me for the presentation in the chat box itself. So, can we have your presentation, sir, for the for people? I mean, we can disseminate to the states and other people as well.
No problem. But you have a recording of it, you know. You are on
Is
Zoom.
the recording is also there, but recording is there, sir. Recording is there, but they are writing in the chat box. They want to learn more, because maybe they will also we will write your. I mean, if you permit, sir, so we can give your mail IDs and other things to these states, so they can have a consultation with you when they need, sir. So they will take appointment from you, sir, and then they will definitely take. So any questions in the states?
These are all doctors. They can have my personal mobile number also, not a problem.
So we will send it, sir. And they have written their, if you can see, they have written their mail IDs also. Everybody wants it. So it is the important thing, sir. Sir, everybody has, I mean, if you see the chat box, sir, you can see that everybody is asking for the same thing. I mean, this was nice, and everybody was so keen, and we had more participants. Now it is 209, and we reached up to 240 people who joined us from different states, actually, sir. It was not from one state, it was from different states and different places, so they have joined us. So thank you so much, sir. And if any questions are there, Nanda, you can ask.
Yeah. Any question? Thank you so much, sir, for giving such a beautiful insights and how to prevent and how we can control this type of severe disease. And so thank you so much, sir. So the now to the participant side. So is there any queries related to the pneumonia? They may write in the chat box, or they may can raise their hands so that we can unmute from our side. So is there any questions from the participant side? They may write in the chat box, or they can raise their hand so that we can unmute from our side. हम चाहते हैं कि लोग ज्यादा से ज्यादा क्वेश्चन पूछे हम लोगों को, सो दैट हम लोग भी और भी कुछ सीख सकते हैं ज्यादा से ज्यादा.
Everybody is asking for the mail. So you can see the chat box is full of your presentation. They only want your presentation, nothing else. I mean, they are well versed with the presentation, and they want to learn from you more. Maybe because of this, they are asking for, and they will join us. So, sir, with your kind permission, we will write to them. We'll send your presentation. We will also with your mail.
You can share the presentation, my email ID and my personal mobile number, which you
Yes, sir. Sir, yeah, that's what we will share from NHA side, from the ministry side, we will share it, sir. Because now people are very much interested, and we should take care. I mean, this is from the entire, you can find it, sir. People from CSC even has joined. And everybody is writing their mail IDs. I mean, I'm very thankful to you, sir, for your kind time and all. And everybody so enjoyed the presentation. The entire presentation was very well,
full of case studies.
Yes. So it was very well defined, actually, sir. And everything was taken up.
So that was important. And everybody is writing you, sir. Can you see the chat box? You can see that. Thank you, sir. Thank you, sir. It is coming up. So thank you on behalf of NHA and Ministry of Health. We are really thankful that you all have joined for a wonderful talk, which was very important to us. And NHA keeps on taking up these such issues because we want to get to the peripheries. Now it's a time when we are talking about Ayushman Pradhan Mantri Bharat Pradhan Mantri Yojana, and we say that we have packages and everybody should avail these packages who require it. This is the most important time, and we also learn about these important preventive and management strategies where we can take up these issues in a better manner. And we are also trying to revise our packages where self will be very helpful, because this is a time when we need to accelerate ourselves to come up to the patient's expectations and that country's expectations as well.
One hand is there, Mr. Arjun. Mr. Arjun,
Pardon,
yes,
sir?
one.
Yes.
Mr.
What is he has asked? Somebody has raised hand? Yes, please.
Yes, Arjun ji, you can unmute yourself. Arjun ji, you can unmute yourself. Arjun, are you there?
Okay, I think it's okay. So, all right, can I take your leave, Dr. Srivastava?
So, any last moment questions from the participant side? The medical students have also joined here also. Any questions?
I think you can cross.
All right.
So thank you, sir. Thank you
Thank you very much.
Thank you so much, sir. Thank you once again. And thank you everybody for joining us.
Just a second, one question is from Case Sridhar. Just a second, sir. Just a question from Case Sridhar. Yes,
Mr. Sridhar.
yes, Sridhar ji, you can unmute yourself.
Yeah, you can ask. So the question is, what vaccination do you suggest for the elderly pop-out? Elderly people, sir. Yes, sir.
Elderly people.
What
So, I already said there are two vaccinations which are important from the lung point of view. One is for pneumonia, that is for Streptococcus pneumoniae, and there are other is for influenza. For influenza, annual vaccination is for pneumonia. Every 5 years we vaccine, but there are a variety of vaccines which are available. One is, if I could take the name because it's not Prevenar 13, and another is Pneumo 23, or that is 23 strains of pneumococcal. That is a polysaccharide vaccine actually. So if you are giving that polysaccharide vaccine, then you have to give once every 5 years. But the Prevenar 13 and others are also coming. You have to give two vaccines. That you give Prevenar vaccine. After 2 to 12 months, you give a polysaccharide vaccine, and that gives immunity for life. But to simplify it, so annual vaccine with influenza vaccine, and every 5 years with pneumonia, Streptococcus pneumoniae vaccine is recommended for. I've already narrated who are the candidates for that.
Thank you, sir. So, any more questions from the participant side, or you can raise the hands. So we are running out of time. Any questions? Hope there is no question. Thank you so much, sir, for being here and giving such a beautiful insights to us. Thank you so much, sir. Thank you so much.
Okay.
So simultaneously, a feedback form has been shared in the chat box. So it is expected from every participants to write about the session, and if you do have any queries related to the pneumonia or anything related to sharing of the PPT, they can write in the in the feedback form. Again, I am sharing the feedback form in the chat box. So you can write, so it is expected from the participants to write about the feedback, and they may write the questions what they want from us, or any further informative sessions you just needed from the NHA. So we'll conduct accordingly according to your expectations. Thank you everyone.
Jala deficiency remote rate कहाँ से लोगे? NTWS अच्छा ओह इससे National Thalassemia Welfare
So in case of the participants are expected, if so,
we will send the
so it is expected the somebody want to get the this presentation, this PPT of this session, so they may write in the feedback form, and will be sending to the individuals those who have written their email ID in the feedback form. So thank you so much everyone. Thank you so much Vinita ma'am. Thank you so much Vridiji, and thank you everyone for joining. And without your presence, this webinar will not be going to be fruitful. So we expect what the learnings which we get today, that must be percolated to the downwards. Thank you everyone. Thank you so much for being here. Thank you everyone. Thank you ma'am. Thank you so much.
video of